Hi there and welcome to another special edition Osler video. My name's Todd Fraser and with me today is Cameron Green, who is the Global Project Manager for the Remap Cap study. And Cam's joining me today to talk a bit about his role in the project. Cam, welcome to the video.
Thanks, Todd. Great to speak to you.
So tell us what your role involves. It sounds immensely complex. What do you do as part of a big project like this?
Well, as you say, Remap Cap is a complicated project. It has a few really interesting design features like response adaptive randomization. It's multifactorial so that we assess multiple interventions simultaneously. It's adaptive, meaning that we can insert new interventions and drop interventions over time. And it's also a large international study with around 15 countries involved. So while these are really exciting features, it also makes it quite complicated to try and manage a project from both a methodological point of view and a logistical perspective. So my role is really to try and support all of the great people that are involved into this trial. So from the International Trial Steering Committee, working groups, statisticians, database providers, and regional coordination teams, to try and sort of support these teams and to coordinate them so that we're all aligned and so that they have everything that they need to do the job that they're there to do.
So give us an idea of what a day-to-day kind of, or what that would look like on a day-to-day basis.
Yeah, so as I've mentioned, we assess multiple interventions. So that means multiple protocol documents. And of course, at the moment, we're adding new interventions and new domains as we go along and as evidence accumulates for the treatment of COVID. So it often involves a lot of working on protocol documents and also preparing things like study tools that can go out to sites to assist them to learn the implementation of those protocols. Often it also involves working on contracts. So obviously there are a lot of people involved in the trial, and so I try and help out to manage the contracts so that we have everything in place so that we can share data and we can work together. It also involves a bit of working with our database teams to make sure that we have our database working correctly, that it works seamlessly for sites so that they don't experience any problems when trying to randomize patients, and also trying to work with them to build in the new domains that we're adding, things like that. But every day is different. Every day has a new challenge, and it's certainly never dull.
Well, what sort of background do you have that led you to a position like this, Cam?
Well, my background is actually neuropsychology. I first became involved in ICU research. Through that, I was working on a project looking at delirium, which is something that's very common in ICU. I spent a year working on a research project in the Royal Infirmary of Edinburgh in the ICU. And I just really love the ICU as a setting to do research. You're working with patients that have the most potential to benefit from intervention. And any benefit that you can offer these patients has a real impact. I also like that it's quite a dynamic environment. And there are a lot of really interesting challenges for the treatment of ICU patients. So when I returned to Australia, I worked as a research coordinator at Frankston Hospital in Melbourne. And that, I suppose, introduced me to the research network that we have in Australia and New Zealand. I was fortunate enough in that job to be able to do a bit of my own research and to manage a few of our own local projects. And then when the opportunity to join Remap Cap came up, I jumped at it because it's a really interesting project and a great opportunity to learn a lot more about these quite novel trial design aspects like adaptive randomization, Bayesian statistics, and platform trials.
So the last few months must have been a whirlwind for you, a lot to do in ramping this up to be able to cope with the pandemic.
Yeah, absolutely. Well, Remap Cap was built to adapt in the event of a remap, in the event of a respiratory pandemic. So after swine flu, a lot of researchers felt that we needed infrastructure in place to be able to respond if another pandemic occurred. So Remap Cap really came about to try and provide that research infrastructure that could be in place and could adapt rapidly in the event of another pandemic. So that pandemic has now arrived. And over the past few months, there's been a huge amount of work. So in the past 2 months, we've added 5 new domains to our trial. And each one of these is essentially a new clinical trial in itself. We've expanded from around 50 sites before the pandemic to over 160 today, and we're continuing to grow. We're also bringing in new regions. So we're looking at collaborating with groups in Asia, in South America, and we've also, it's quite exciting, we've brought on partners in the United States as well. And one of the more recent developments is that we're expanding to include non-ICU patients. In a lot of settings, there currently is a lack of trials in the hospitalized setting. And so where there is a gap in that space, we're expanding Remap Cap to be able to fill that role.
And just finally, Cam, one of your roles obviously is to support new sites coming on. What are the sorts of things that sites need to consider before engaging in a trial like this?
I think first of all is don't be daunted by the complexity. We do a lot of work behind the scenes to try and manage that complexity. We have a great team of people working on this, from our database to our international trial steering committee and our regional managers, and we try and make it as seamless as possible for sites. And so our aim is to make it look like any other trial at a site. Another thing that sites should be aware of is that it's a really efficient way to evaluate multiple interventions and multiple domains of therapy at once. So you can essentially do 6 clinical trials in one. Importantly, you can also pick and choose which domains and which interventions you're going to deliver at your site, depending on what's acceptable. So you don't have to participate in all domains or all interventions. And I think this is a really efficient way of evaluating these questions in critically ill patients, because we use response adaptive randomization. This means that any patient that's enrolled has the benefit of evidence that's accumulated from previous patients. And it means that every patient is most likely to be assigned to a treatment that is most likely to be beneficial to them, which I think is something that a traditional frequentist trial can't offer. And I suppose most of all, we would just like to say thank you to all of our sites who are already participating. We're eternally grateful for all of your hard work. This is a really difficult time to be doing research, and we appreciate everyone who is working on this at a site level. No trial can succeed without the hard work of all the people at the site level, enrolling patients and delivering the interventions and collecting the data. So we're very grateful for everyone's hard work.
Very well said. Cam, thanks very much for joining us on the video today, and good luck with the rest of the trial.
Thanks, Todd.